My name is Dr. Aaliya Bibi, and I'm the lead for health programming with Plan International based in Toronto. I am a medical doctor trained in medical expertise in the field of maternal newborn child health as part of my background. My passion and commitment towards the work that I do comes from my childhood. I was born in Pakistan, where many of the people around our line of work would know that the health outcome indicators have been worse, and especially in the health outcomes for mothers and newborns, children and adolescents have been worse than lifetime. Based on the things that I saw around me and people's lack of access to healthcare or information or education, I did prepare my mind to go towards the medical field. I got my medical training and I did my postgraduate studies. But during my tenure, I worked around the world on maternal newborn for a long time. This project, the Strengthening Health Outcomes for Women in Nigeria, was a maternal newborn health-focused project aimed to improve health outcomes for women and adolescent girls in this area. The rationale for this was that Nigeria, now the figures have improved, but Nigeria typically has been a country with the highest burden of maternal mortality. That is, mothers are dying and newborns are dying during childbirth. It stands fourth globally in terms of contributing to the burden of this mortality. Around 28.5% of global maternal deaths have occurred in this part of the world. I was looking at a 2023 report, and around 700 women died every day due to preventable causes. And I would like to emphasize on the term preventable causes, that these are the causes that no mother and child should die. These are the causes that do not need any high-tech support, medical support, or state-of-the-art equipment, but these are causes that, if paid attention to and prepared for, can have better outcomes. When we look at the health of the women deeper within Nigeria and then within the northwestern context where Sokoto state is situated, the situation is worse. Women here face 1 in 19 lifetime risk of dying during pregnancy. And things become even more difficult when it comes to adolescent health. Adolescents between the ages 15 to 19 are twice likely to die during childbirth. And then girls that are lower than 15 years are 5 times more likely to die during childbirth. Another added layer on top of all this is that child marriage is very prevalent, and that's why you could look at the adolescent indicators being worse, because girls are getting married early on. And then there's a whole paradigm of religious and cultural layer of challenges that comes into force. There's a technical and medical aspect of barriers, but there's a cultural and religious aspect of barriers that makes things worse. Cultural and religious factors can play both a barrier and an enabler role. Talking a little bit on how it's a barrier. Within the Nigerian context, whether we look at Muslims or Christians, it is deeply enmeshed within cultural and religious structures, and the maternal health outcomes are really closely related to it. When we say closely related by culture, what happens is that there's a lot of gender inequality that we see through cultural barriers. Women do not have the decision-making authority when it comes to making decisions for their own health. Financially, they are highly dependent on their husbands or their in-laws, so they don't have the money to access healthcare or to take care of themselves. Especially when it comes to childbirth, we all know it's so important to have antenatal care, having access to a trained healthcare provider, which then it is not available for them because they cannot afford it themselves. And the social norms around adolescents, again, is that adolescents have to prove their fertility. First, they get married very early on, and then as soon as they are married, they have to prove their fertility and bargain their career in education over being reproductive mothers. If we look at it from an enabler point of view, the culture and religion could be really supportive, given the fact and the position of the religious leaders within the context of Nigerian culture. These leaders are highly respected and they're very influential. They are not influencers, but they are the champions. They lead the way. So involving them and engaging them in open, honest, and clear communication to support this journey, I think, was a target that Plan International saw could be achieved. And then again, these faith-based leaders have a great influence on working on the gender dynamics also. We talk about gender inequity, we talk about the low socioeconomic position of women in this culture. This all gets changed when the religious leaders become your advocates. They talk about women's rights. They talk about giving decisions and autonomy to the women. So partnering with them to promote health messages grounded in religious texts can shift norms around maternal health, family planning, and even gender roles. For example, when it comes to religious leaders, advocating for antenatal care or safe delivery makes a bigger impact in terms of practicing at the ground level. So at the heart of this initiative was a deep respect for community knowledge and leadership. Rather than imposing external ideas and solutions, the project prioritized listening to these community participants and leaders, co-creating with them, building a sense of trust so that they could be open and honest communication and not having any hidden agenda. Let us remember that people within these communities know more about themselves than any outsider would, and hence they would have the best solutions too. So the participatory approach that we focused on meant bringing in community voices to shape and design this intervention. It included identifying barriers to designing the approach that could be culturally sensitive, grounded within the culture. It ensured that solutions are also realistic. Moving on and focusing on religious leaders in conservative settings like Sokoto, the religious leaders are not just influencers, they are the gatekeepers of the social norm. And recognizing this, the project engaged them early and meaningfully so that they are part of the process. And because they are the anchors, key decision makers, they were not just passive messengers. They were leading these interventions and designing them. They were helping in shaping the messages and strategies that aligned with both the goals of the project and also religious values of the scripture that they reference to. So what we did was we did a sensitization session. First of all, we identified them who are the key religious leaders at the top level that we need to talk to, take their blessings, include them in this journey. And we did a sensitization session with them on what the project was about, being very open. Let's remember that working with a religious leader is not out of challenges. And if projects bring something with foreign funding, it's always viewed as a Western agenda attached to it. So it was very important for us to clearly put down the communication plan for the project on what it was about. It was improving maternal mortality and child mortality. We had their faith and their trust. So the trust building is where it started. And then they took up the role of communicating with their chains of command to talk to the other religious leaders to bring them on board. They sat with us to talk about the next steps on how the rollout will happen. That was a bigger kind of groundbreaking piece that we had to focus on. The simplest thing is the project moved from dialogue to action. We started with the orientation and sensitization of the top leaders. They put all their command chains together, other leaders at the various level, at the lower levels, at the grassroots level, to come together as a group and brainstorm and come up with something that is simple and acceptable by the culture as well as improving outcome. What they did was that through the leadership of their leaders both for Muslims and the Christians, they were bigger groups of religious leaders, meetings of religious leaders, consultation sessions that they did internally. The project team was there to support and give them technical knowledge on health, but they were the ones who had the Holy Quran and Bible with them, and they went line by line to look at what piece of the scripture actually supports and brings out the importance of maternal health, breastfeeding, family planning, importance of gender role. And they started picking up scriptures one by one from that content and started putting it together into a manual for maternal newborn child health. That's what we call it. And that was not just men, there were women religious leaders also present in these consultative sessions where they were very vocal about women's role and bringing it to the forefront. That was a very interesting and helpful exercise. What for the project also to see that there was such a lot of wealth in the Holy Scripture that was actually supporting the women in their health journey and adolescent girls too. One of the most visible successes of the project was the transformation of religious leaders into public health advocates. After participating in orientation sessions and co-developing the faith-based messages on health and better outcomes, so that kind of started adding up together in terms of making it a campaign, not just a project. So it became a campaign of where faith-based leaders were trusted and engaged and community was leading. So they not only started speaking with their own communities, but they also started becoming vocal advocates by speaking at local radio stations. There would be weekly sessions where a renowned religious leader would come in and sit on a panel and give very important, culturally appropriate messages on how people need to be careful and make sure that the women give birth at health facilities, they have antenatal, girls don't get married early, they focus on education. So all wonderful messaging was then given by these religious leaders at these radio spots and multimedia. One step further than that, I would say, is that this health movement moved beyond borders also. These religious leaders, let's remember, some of them have got viewership and followership because of the digital media with people beyond Nigeria too. They started using that followership too, and not just that, but they started presenting at international fora. Some of them were invited in international maternal health conferences where they started talking about the faith-based approaches and how they can actually drive health equity, bringing them into that commitment, that community-led commitment, strengthened local systems. No project comes and no results are achieved without challenges. It's just how we try to learn them early on and try to strategize for that. Working with the religious leader also did not lack challenges. To start with, something that we really had to be careful on the start was never be scripted, because we were navigating in a territory which is highly sensitive. Talking about religion, getting to religious, for the longest part, I've seen my colleagues do not interact into sensitive paths, but here we were getting the sensitive leaders to come on our side of the table. So I think that was something that we had to be careful and mindful that we do not bring in our prescription, that expecting them to say what we want them to say. But what we did was we presented to them what the situation was and what needed to be done. What do you think can be done? And then using the scripture, what is it that could come in? So that journey was a lot of learning and sharing, because during the consultation process, the kind of scriptures that they would pull out from the Holy Quran, the verses they would pull out, because when you pull out scripture and verses from a context, sometimes it changes meaning when it is just portrayed as a statement. So there were certain statements that were not viewed as being softened towards impact on health and indicators. So that was again learning process, that whenever the religious leaders are bringing out something of the context, they need to put the context in place so that understanding is simpler, because the message is going down the chain. And then again, learning from each other and peer-to-peer. There was another challenge that we had within this project was working with the state. We were working on a peer-to-peer manual for education of adolescents or information sharing of adolescents out of school. This peer-to-peer manual was sitting within the Ministry of Health for years. We kept on changing, going to and fro, doing the reviews that they needed. But at the end, they told us very straightforward, very honestly, that we cannot move because this is very sensitive. Sexual reproductive health is a sensitive topic, and there's a lot of religious influence. We cannot move ahead with this unless we have the religious leaders validate. Working with the religious leaders and having already that trust helped us. So we had a round table with the State Ministry of Health, with the religious leaders and the project team, technical team, to walk through the peer-to-peer manual for adolescents line by line. The religious leaders were the ones who were correcting us, guiding us. How do you tone down the language here? How do you use an alternate term here? Because culturally this term may not sit properly. So that was such a helpful process. And I tell you, after that, the peer-to-peer manual was approved by the Ministry of Health. So that was a big challenge. There was a learning process and there was a success that rolled out, and it's still there. this story from Sokoto, and then later on it evolved to Bauchi State also, it's not just about health. It's about trust, dignity, and the power of local leadership. When we listen to communities, when we work with faith, and when we respect cultural context, change is not only possible, it's sustainable. So my ask, if we are talking to global health actors, those that make the strategies for global health, they need to invest in faith-based and community-led approaches. Right? If it comes to government and donors who set aside their strategic objectives, these governments need to support gender transformative programming that centers the voices of women and girls. And if it comes to partners and practitioners, it's important for all of us to understand that we need to co-create solutions with those who live in the realities every day. And the answers are already there.